Okay. So to everyone, we're playing around with this format and we learn every week when we do these things, but what's really worked in the past is that we have our panel members just kind of share a little bit about who they are, what they do, what's going on in their organization, some insights from the front lines that they may have, what's on their mind right now. And then during that time, we can, ask questions, engage in discussion. It doesn't necessarily have to relate to what me or the panel members are talking about. I really like this sort of the open discussion. So for everybody who's attending, basically, if you've got a challenge, if you've got a question, if you've got a concern, this is a great forum, and we're all engaging together while we're meeting two unique practitioners and learning about what they're doing. So that's kind of the format. And so Deanna, I'll start with you first because you're filling in for Dr. DeJonge. Really bummed that we don't have him here today, but I totally understand it. I can only imagine what his schedule's like. For those of you who didn't attend, well, I'm going to let Deanna talk a little bit about what Capital Caring is doing with their primary care at home and kind of give us an update on where things are. I'm really curious about where the program is going.
Thanks, Steve. I appreciate that. I'm also super bummed that Dr. DeJonge couldn't present today. So just a little bit about me. My name, again, as Steve said, is Deanna Cho. I'm one of the social workers with primary care at home. And Capital Caring Health is, I guess how I would describe it, is our parent company. We're a new service line out of Capital Caring Health. And we are called Primary Care at Home. We provide home-based primary care. And I have been doing home-based primary care, or HBPC to be really short there, social work for about 3 years with MedStar House Call program. And I was actually working with Dr. DeJonge at that time. And then I had a brief sojourn into DC Long-Term Care Administration. And then Dr. DeJonge called me back into the field, so to speak, when he started up the primary care at home practice about mid-summer of last year. And then we really opened our doors and started seeing patients this January of 2020.
So for everybody there, and one of the cool things about these weekly sessions is we kind of learn about the different practices. So last week we had Dr. Dappin, who is basically charges in 5-minute increments and doesn't use any insurance, and really has this very unique practice. The Capital Caring Health primary care at home is a very unique in several ways. Can you kind of share how that works?
Yeah, so we actually started out, because we're new, we get to have a lot of flex with how we want things to be. And what we started out with was a model where we did have private pay fees, and we had a fee structure. So a sort of high fee, middle fee, and a low fee. But we actually eliminated that altogether as the months went on, because we just felt that it wasn't working well for our patients and caregivers. There's a lot of challenges with having to pay that fee, even though they found the service to be incredibly valuable. And just as a background, the reason why we have that fee is because insurances don't fully cover the cost of running a house calls practice. One of those costs, great example, is a social worker. So Dr. DeJonge really believes that social work is very important support for our patients and caregivers. And so when we started the practice, we had thought having that private pay fee structure would be a way that we could cover costs of travel time, social work support, et cetera, et cetera. And then we just found that it wasn't really feasible for our patients and caregivers. And so we eliminated that, and we are just billing insurances. So Medicare, other plans that accept house calls medicine. And, does that, I hope that covers your question.
Yeah, well, now, I remember from the kickoff meeting, you're tightly focused in some geographic areas. And the concept is, and it really, everybody got really excited because it was sort of like, look, we're focusing on these geographic areas. We need to get X amount of patients in these areas. Then we can expand to the next area.
Mm-hmm.
Share a little bit about what regions you're in and kind of where you're at with that process, because I think everybody seemed to be very excited about this covering a larger geographic area.
Yeah, so right now, the DC, Maryland side, we're really in Chevy Chase, Maryland, and upper Northwest DC. So we are continuing to grow slowly but surely. For our Northern Virginia side of the practice, that side of the practice is also continuing to grow. I think what's been helpful for us is making relationships with a lot of the providers that are in the field, whether that's specialists, and also the facilities. It's going, I would say, slower than we had hoped. And then, you know, the pandemic obviously makes things more difficult, because everyone's processes are so different now and changed.
Yeah. Well, I mean, that's one reason I'm glad we've got you on here. I've been doing this for 30 years, and I found that every single sort of pioneering business, meaning that there's not 20 other organizations just like you, that every pioneering business, it's always slower than expected, you know, and I know that's frustrating, but I guess just because I've seen it so many times with kind of unique ideas, pioneering ideas, but once they start getting traction, it makes a difference. So, well, thanks for that. We'll definitely get back to you, but I want to give Christine a chance to tell us about your profession and kind of how your organization works and all of that.
Okay, so thank you very much, Steve. So I am medicine at home, which means I have a small house calls practice in this Montgomery County and PG County, Maryland. I've been practicing house calls for about 8.5, 9 years now. I started my own practice about 5 years ago. I'm in my 5th year. Medicine at home is we're home-based primary care, serving the homebound Medicare patients. So I'm 100% Medicare. I believe that benefit is extremely valuable. I think our citizens worked very hard for that Medicare, and now it's there in place and designed to keep my patients out of the hospital, off of unnecessary medications, and thriving at home as long as possible. I do follow them if they go into the assisted living, and I do have 50% of my practice in small group assisted livings. I don't go into the large corporately owned for many reasons. It's really a business decision on my part as well. But these smaller group homes I believe in Maryland and PG and Montgomery County. So that's, I take the, of course there's supplemental insurances, so Medicaid and then the regular commercial supplementals.
Now, your actual credentials and your being a physician's assistant, correct? That's
PA.
A PA, yeah. Tell us a little bit about like what can a PA do? You know, I mean, okay. I know when I went into a primary care physician's office, 9 out of 10 times I wasn't talking to a physician in the last, 10 years. It's like nurse practitioners or somebody who I didn't even know what their credentials are. So I could have been speaking to a physician's assistant for all I know.
Sure, and oftentimes we are trained to across interdisciplinary. So we're trained from everything from emergency medicine, surgery. Primary care is our historical foundation, and I focused in primary care, internal medicine, and geriatrics. So PA is it's a physician assistant, formerly known as. But we are medically trained as a actually equal to most all foreign trained medical doctors. The American system is a little more robust in training American doctors. So, but my medical training, I can prescribe medications up to Schedule II medications. So I have but the law requires that I have a physician to sign, well, not sign, excuse me, that there is a paper filed in the state board of physicians that we are a collaborative delegated. It's a delegated agreement, but we're a collaboration, so that I can go to him to ask for advice. He's there as my medical director, but essentially it is a legal arrangement. Otherwise, I sign my own orders for home health and hospice now. So I'm pretty fully almost in terms of the practical clinical approaches, I'm relatively independent.
Okay. What would there be, what are some of the elements where you absolutely, where a PA needs to kind of say, you need to speak to a physician?
Well, if it's outside of my scope of practice, if it's outside of my training and outside of my experience. Okay. So I'll refer to a cardiologist if if I just can't simply continue to control the out of control blood pressures. Of course, if there's a new AFib, I'm going to refer to a cardiologist. So I refer out when necessary. Cool.
Okay. Well, thanks to you guys for such a great overview. So now, I'd love to hear some experiences from you, and also remind the attendees that if you want to raise your hand to talk, if you want to ask a question, it's best to use the Q&A box for questions, and then use the comments for more networking and sharing of resources. So feel free to do that, attendees. But while we're waiting for anybody to sort of jump in there, tell us a little bit about what's going on the front lines related to sort of COVID-19 and your all's clients. Deanna, do you have something to?
Sure. So for primary care at home, we have been really fortunate because Capital Caring has a lot of technological support that we're able to provide our patients and caregivers. So to start with, we've switched a lot of our visits, all of our visits really, to televisits. And for initials, for new patients or for urgent visits, we are able to do those in person. Of course, we're going to don all the appropriate PPE, like face shields, gloves, gowns, as necessary. For all of our visits, we're doing that screening call ahead, no matter if it's a televisit or if it's an in-person visit. We're always going to do the phone screening, so we have an understanding of how are you doing, how is the care system around you doing. And then also for those who don't have a smartphone, or maybe they don't have the technology, we've been able to provide them with smartphones during this interim. So we have a list of those patients and caregivers that need a smartphone and have sent that to them. And we've gotten really a lot of support from the volunteers that usually serve only our hospice side. They've opened up and been able to provide support for the primary care home patients. So we have a Zoom crew of volunteers that can help our patients, help our caregivers to set up Zoom for visits. But really, even the smartphone itself has already been set up with Zoom. So you turn it on, and Zoom is the only thing that you can use, and it helps to just ease the access of this new technology.
Well, now you're a social worker. So what does and Christine, there's a question from Judy that says, can PAs admit to a hospital in Maryland?
Well, I mean, we admit, no, I don't think that's, it's a 911 call, and they go, or they usually, if this is handled through a specialist, if it's a special situation, but I've never had any issues of admitting like that. It's really just, if they need some type of surgery, they're already seeing a specialist.
Okay.
Yeah.
Um, Great. Okay. Good question, Judy. And Deanna, as a social worker, what is, I'm just kind of curious, what did your day look like before COVID-19? And this is a good one for you to be thinking about, Christine, as well. What did your day look like before COVID-19, and what does it look like now? You know, and I'm kind of curious because there's some things in my life now that I feel are way more efficient because of COVID-19. Like I'm utilizing technology better, or what have you. But I'm curious, any kind of insights on that?
So my day has become, yes, more effective and efficient as a social worker. And I think any provider of services for older adults, um, effective and efficient doesn't mean that that's what the patient and caregiver are fit best for them. So I'm able to pop in right at 8:30 and have a visit with my patient and caregiver, and then go into my next Zoom visit, which is great, I guess. But before I would, go. I would have a visit that went as long as it needed to, as short as it needed to. Um, and then I would walk or drive to my next visit with the patient, and that's maybe anywhere from 15 to 30 minutes of driving and trying to find a parking spot, trying to walk through the building and getting lost in buildings. So all of that has been taken, and to some respect, that's great. In others, I miss, as my patients and caregivers have said, the physical contact. There's a lot of just connection that happens when I put my hand on my patient's shoulder and look them in the face, like eye to eye, and say, that is very hard. So there's, good and the good and the bad and the ugly.
Yeah. Thanks. How about you, Christine?
Wow. So it's been actually a very heady experience, regardless, in the face of the tragedies that are going on around us, I've been able to really retool the practice to being 100% telehealth. So I'm still experimenting and piloting platforms for the HIPAA compliant approach. But, now CMS has allowed us all to use non-HIPAA FaceTime. So that's been amazing. I'm doing physical exams that I never dreamed of possible, that I had no idea I could do. I could check oral cavities for pocketed foods. There are orifices that I could see that never would have normally been in my physical exams. So I'm 100% telehealth. All of my patients have been great at having a smartphone. The caregiver has a smartphone, enlisting family members who have smartphones. So I'm finding that there's a lot more ownership and accountability on the side of the family and caregivers now than ever before. They're really involved, especially with that physical exam, for instance, taking the vitals. So I also have, I'm doing remote patient monitoring. I am now monitoring my patients remotely, their physiological biometrics, their blood pressures, essentially, all of my patients every day. So I literally have my fingers on the pulse of my patients between visits. They still call me and text me, ask me questions. I'm still very flexible. I'm not as efficient as I'd like to be because I do respond when I need to. So I'm finding myself actually working more evenings, weekends, times that I wasn't working before. And then I also have a outreach program that I developed with my interns from University of Maryland. I have about 7 interns. They call daily. Some of my patients need daily calls. We're checking for caregiver burnout. We're checking for COVID symptoms. And we're just talking to them. And really, I need to reduce that sense of isolation with my patients who suddenly they're not having their daughters visit them every day. The caregivers who really are down to maybe 1 caregiver when they had 3. So this has been just very valuable time for, really kind of mastering the pivot, as I say, but I think it's actually really kind of skyrocketed the robustness of the telemedicine approach. And I appreciate that part.
Yeah, I mean, it really is. I mean, again, it's a tragedy, but the fact that clients are speaking to their healthcare practitioners in this way is really amazing. You know, let's see. And another thing, you mentioned up remote patient monitoring a few weeks ago. We had somebody talking about that, and it was, they basically said the physician needs to be the starting point to engage remote patient monitoring. So as a PA, you can be that assigning party, correct?
Yes, that's it.
Okay, great. And Deanna, does your practice utilize remote patient monitoring?
No, not as far as I'm aware. The sort of mobile technology that we use on a regular basis is usually the vital sign kit that we provide all of our patients. So that's where we're able to get a sense of their oxygen level, temperature, and their blood pressure. And usually when they're doing a call or an urgent call, we'll ask them to use these 3 sort of tools that we've given them so that we can get a really good read of how they are in that moment.
Okay, great.
That sounds like remote patient monitoring to me, Deanna.
Yeah.
Thanks.
Well,
it sounds like it, but I wasn't sure. Thanks, Christine.
It is.
yeah, well, you know, what I discovered on that remote patient monitoring call that we had is that it's like, you know, there's other ways to sort of do some of the RPM, but to call it RPM and have it coded on your Medicare form, I guess. But I agree. So some good questions are coming in. Martha asked, can PAs sign most forms in Maryland?
Absolutely. We sign most forms, and remember, they are durable. You only need one signature at one time unless status changes.
And I forget what most is. It's Maryland.
Orders for life-sustaining treatment.
Orders for life-sustaining treatment. You know, one thing, I don't want to digress on that, but you know, I've been to a lot of advanced care planning seminars and heard a lot of people talking about advanced directives. And a lot of times the example that they bring up is they say, well, for example, in my advanced directives, it says, I do not want to have a ventilator keeping me alive. Like I've heard that multiple times. And I was recently on a webinar where somebody was speaking on this topic, and he was saying, you know, what we need to do in our future advanced directives form is be more specific. I permit a ventilator to, I forgot the wording, but the way that a ventilator is being used in COVID-19 is much different than the way that most of us visualize a ventilator being used in keeping us alive for weeks or months, you know, so interesting insight there. So let's see. For Deanna, this is Catherine McCallum. For Deanna, what Medicare coding are you submitting for clinical social work provided? Have you had denials or rejections for reimbursement for services rendered? What social work services are you providing that cannot be reimbursed, and how is your practice covering that cost?
That is like the $1 million social work question. So, Catherine, for home-based primary care social work, there is no reimbursement. As far as, you know, our practice is aware, and we are members of the American Academy of Home Care Medicine and have been there, you know, years on end. And we have not found any funding or reimbursement through insurance for a home-based primary care social worker. So I just want to make that distinction because there's been some confusion from, for example, skilled care agencies are able to provide reimbursable social work services, but for a home-based primary care practice, ongoing primary care for, you know, for our older adults, that social work is not reimbursable through insurance. So we're not reimbursing for insurance. And really, I think it speaks to Dr. DeJonge's commitment to provide the social support for our patients, because there's no reimbursement other than our census getting to a certain volume that we can support services like what I do.
Great. Thanks. And Catherine, hopefully that was helpful. I know reimbursement and all that stuff is just so challenging, which again, last week we had Dr. Dappin, and he just gave up on all of it. And he just charges, now. So Patrick O'Shea has a question. Zoom has had some accusations of privacy security holes. FaceTime is not a record as auditable, yet CMS has temporarily relaxed rules around telemedicine. What is your long-term care strategy with regard to telemed and still achieving privacy, security, operational efficiency, and patient satisfaction? Disclosure, I'm working for a young company addressing those issues. Hey, Patrick, we'd love to have you on here because we're going to have a whole, I'm trying to do weekly seminars on sort of the future of senior living. And in fact, next Friday, we're going to focus on some technology. So make sure you send me an email because I'd like to have you as a moderator and share some of that. But curious with your thoughts on FaceTime and Zoom and HIPAA and all that stuff.
So I think one thing, what they're going to end up doing, CMS, in terms of after the emergency period is over, what are they going to decide as far as can they put the genie back in the bottle, so to speak? I do think that they'll have to, of course, go back to, have to have absolute HIPAA and HIPAA compliant platforms. And plenty of them exist, very affordable ones. But I think also going further in terms of privacy, I think it should be, there should be a discussion before, if you notice people are in the room, make sure you talk to the patient, say, I noticed that there's somebody in the room. Do we have your permission? Is this okay? Do you feel that this is private? Can we relocate? Always have these discussions with caregivers in advance, making sure that there's a private, that there is a private area provided, documenting that in terms of that there was permission given, there was consent for that visit with regards to privacy issues. That's some of my thoughts.
Yeah. Deanna, I mean, you had mentioned you're using Zoom and you're coaching your clients up for Zoom. Now, out of curiosity, would those conversations in like reminder calls, would that be sort of framed under HIPAA? And maybe, I don't know if we know that, if it's just, calling in to check in on Zoom, would that need to be a secured platform?
So from my understanding with our IT department, we are on a secured platform or licensed with Zoom for all of our Zoom visits. And then we've, the landscape is constantly changing. We're all flexing as things change. So for example, we'll get just in the practices that we're using to make sure that we don't have, this is a new term to me, Zoom bombing, or, people will come in. I was like, what the heck is that? But we're incorporating things like locked passwords and for sessions and things like that. So that's really all the sort of info I could provide on the technological HIPAA compliance aspect.
Yeah, no. Well, that's good to know that your Zoom platform is secure, and I'm assuming Zoom has some kind of HIPAA overview. I think the fact that FaceTime and Zoom are just so easy to use is why they're so widely adopted, and that's the key is that hopefully the other HIPAA platforms can be just as easily adopted. Let's see. Catherine mentions Zoom and others telemed have HIPAA compliant levels. Let's see. Todd has a question. Senior Handy Services offers transfer and mobility service for in-home patients. Our mobility transfer clients are an immediate need. In most cases, they are hesitant to have our staff in home due to C-19. Is there anything we might offer beyond PPE to build their sense of health security? Really good question. And actually, I'd love to pose to the two panelists to share some thoughts on Todd's question, but also PPEs in general. And for the attendees, it's what's going on out there as far as being able to get PPEs, to use them properly, and would be interested in hearing what about that. Do you guys have any thoughts on Todd's? Like, what are some ways that when somebody's visiting to do a transfer or mobility, you know, how can we give the clients more confidence on that visitor is not infected?
Did you want to start with that, Christine?
Oh boy. So, well, I made my choices to limit my visits just basically to protect my patients from further anxiety, even if in reality I'm completely, I've taken all the precautions. There's still a high level of anxiety regardless. The procurement of PPE, yes, is an issue. And I know that, we're kind of all scrambling, finding our own resources. And I know even, as recently as this weekend, there is a friend of ours is trying to distribute through donation only N95 masks. So things are just really kind of from my own observations, it seems to be a bit of a Wild West still right now. So that's what, I can't, you can't wave a magic wand. I think that speaking to the perhaps asking the patient, I've asked my patients, why don't you just call the company directly, speak to them directly, ask your questions about, what, and if you feel there's a level of assurance there, then, but I think right now it's a very, I think, honoring those boundaries is very important right now.
Yeah. Any thoughts on that topic that Todd might be helpful for Todd?
I just wanted to add to what Christine was saying with the fact that I think there's, as Christine mentioned, a lot of emotion, a lot of fear and anxiety. And this is where having a long-term relationship or even just a relationship that's supportive to the patient that really helps you to get through, to provide factual information about care. So in the example that he gave, I would say, do you have a care manager, a caregiver, or physician that you trust that you can ask them what should be done in the situation, and making yourself available to be on that phone call so that they can say, well, what are you doing to protect yourself? That sounds appropriate. Or, helping us all to have a conversation where the fear and anxiety can be aired in a sense. And then the process of what we're going to do can then be put in place. That's what I would.
Yeah, I really like what you just said and this is great for all of us, is, sometimes like the client would be, if Todd was like, we consult with Dr. Smith, okay, and we are following the protocol that Dr. Smith has advised us on. And if you'd like, I can make an arrangement so that you could talk to Dr. Smith's office. So it doesn't sound like it's sort of my company's propaganda. It's sort of like there's this outside advisor that we're using. I think our clients just need confidence, and so hopefully that's helpful. I'm curious for the two of you and for our attendees on the topic of PPEs, share with me like how challenging or difficult this may have been in getting proper PPEs for your staff that's visiting clients face to face?
So for Capitol Caring primary care at home, as far as I'm aware, our staff are all able to, we all have a stock of the PPE that we need for visits, urgent and initials, and we don't have a shortage right now. And I think that actually spans across all of Capitol Caring, the hospice and palliative care services for this time, as far as I'm aware, which is really great. Because naturally, as an organization, our sort of niches, advanced illness, end of life, older adults. So it's incredibly important population to have the appropriate PPE for.
How about Christine? What's been your experience with PPEs?
Well, right now I have an adequate amount of N95s, gloves, masks, shields, and booties, and then my own gowns. So for me, I'm fine, and I am a staff of one.
Yeah.
So and I, again, limiting my visits. I'm doing new patient visits right now, 100% telehealth. So and I haven't seen any patients for at least 3 weeks now, touching. I had to remove some staples. That's something you have to do. So I am limiting it right now. And I think with all the other close approaches that I'm employing right now, everybody seems to be stable, and we're keeping our fingers crossed. But for myself, I'm fine. If I had a staff of several NPs out there with me, I think I would feel a crunch, because I think the smaller, the smaller organizations are having troubles. The smaller assisted livings are having a tremendous time. I mean, these caregivers are really just putting themselves out there. And I worry about the smaller group homes. They don't have the resources. They're under resourced. Most of those caregivers are without insurance or underinsured. So I worry for them.
So I'm assuming, like, in some of your small group homes that you're servicing, that they may not have an adequate supply of the PPEs. Yeah,
correct.
No, it's heart-wrenching. Karen McPhail has made several really good comments in the comments section. There needs to be more consistency and a better standard set to skilled nursing centers and others at some skilled facilities that are not disinfecting properly. Also, Karen made a comment about a future webinar, which I think is great, is to maybe feature some RN care managers and skilled nursing and assisted living admissions staff to kind of share with us behind the scenes of what's going on in those environments. So I'll try to get to work on that. But for everybody on the call, if you've got a resource that might be willing to come on here and share and kind of be a part of a discussion, I think that would be really helpful. Okay, let's see. How about if anybody wants to jump in and raise their hand with a question, comment, challenge. I'd also be really curious about the PPE situation that's out there. Let's see, Biza has a question. Do you have a designated team that is designed to care for COVID-19 positive patients? I guess, do either of you, do your organizations have anybody who's tested positive or showed symptoms yet?
I honestly have not. And nobody in my practice, none of my patients have been tested COVID positive. They have been tested and negative, fortunately. There has been an exposure, but fortunately my patient was isolated in time. I will say, though, unfortunately, the early days of this, when the early days is just 3 weeks ago, there may have been a patient of mine that passed from COVID. Now I would say presumed COVID would have been, but it happened so quickly, and there was she was set up for it. But since then, things have been very stable.
Deanna, I know Dr. DeJonge, in his message to me, said that he was dealing with a COVID-19 issue at a nursing center, have any of your patients had complications?
So right now, the primary care at home patients, all of them no one has COVID-19. We did test one patient, and there continued to be concerns whether or not that was a false negative. So we're proceeding forward with the precautions.
Mhm.
But having said that, right now, there are no primary care at home patients that have tested positive for COVID-19.
Okay, great. So, and I imagine though that both of you are imagining, I mean, this is fantastic that it's okay now, but you're sort of prepping yourself for the day that you do have potentially a positive case. Let's see. Bree made a comment on the PPEs that at one of the previous forums we were talking about sort of grouping home care providers together potentially so that they could buy PPEs in bulk. And I thank Christine for introducing me to Greg, but if you're on our pro-aging online forum, you will notice that we posted a request of a benefactor is trying to get PPEs in the hands of providers who need them. I mean, he's not doing this to make a profit. He's just trying to break even, and he's been purchasing. He's got his first order that came in, and he started mailing those out, and now he's keeping his fingers crossed that he gets a second very large order. And his hope is that he's going to be able to give PPEs to providers that need it at cost, and or as just a gift, and then he's asking people to make a donation, and as he's going to use that funding to order more, and hopefully can kind of get us through this crisis situation here. I was absolutely blown away because what he's been very transparent with me that it costs him $2.50 a mask is basically when it's all said and done. Okay, so that's what his recommended donation is. I met somebody who said that they could get 1 million PPEs, and I was like, oh man, well, if my minimum order is 1 million PPEs, I'm going to be getting these things for a great price. It shocked me that the price was $6 per mask. So that's a $6 million minimum order. And here's this generous benefactor going out there and getting these for $250. So it's the Wild West out there when it comes to PPE.
And I'd like to
It's
speak
really
on
sad.
this further, Steve, if you may. There's also the Wild West is going on, and we have to really beware of the bogus tests also. So right now there's a huge market for tests, and they are producing tests primarily in China that are bogus. They're IgG, IgM antibody tests. They're point of care, immediate results tests, and there's nothing that has been approved or reviewed by the FDA as being accepted in this country for that type of testing right now. We have Celex, which has just recently been reviewed as acceptable, but that's a serology test that you have to send off to a lab for centrifuge. It's not a point of care test. So we really have to be careful with these, people claiming they can deliver these items, and you really have to do your research and really have to ask all the questions.
On the testing, Judy Grumbly asks, how hard is it to get a COVID-19 test in the DMV now?
Are we talking about the swab, nasopharyngeal swab?
I guess just any test, like how have you tested your guys' patients? And
I do nasopharyngeal swabs, and then they're sent off to a local lab, and that result comes back. It's been coming back within 2 to 3 days.
Deanna?
Here at home, we have a team that is available to test all capital carrying and primary care at home patients, and we have not right now we don't have issues with having enough tests to do the testing. And then we have I think it's a relationship with a lab as well to be able to process those tests timely.
Let's see. The Eileen Wilkinson asks, are false positives due to unapproved tests? You know, concerns when I hear that this exists.
Yeah. So we don't know why. It could be that it was correct. Our concern was that it was a false positive because the symptoms were so, they mirrored what we would expect with a COVID case. And I don't really have anything more to say to that. But the COVID test that we use, you know, they're the authentic real test. And we're sending it to a lab for processing, and we get those results usually within the week. So that's all I can really say about that.
Great. Let's see, Karen, thanks for being so active today. Karen has a question. It would be helpful to hear from some individuals who have hospital discharge planned for those COVID positive, people who do not know what the options are for individuals post-hospitalization and how to access these options. Yeah, I tell you, if we could find some folks that have gone through their patients being discharged from the hospital, that would really be interesting. Thank you for that.
But also a very good time for this patient who is needing isolation or continue to be, you know, monitored closely. This is a house call. This is a perfect patient, a patient that really does need a service of our services for a house call and monitoring. I mean, technically speaking, everybody's homebound by order. So this is not just for the sick and active sick, but really there's so many frail that need our services.
Yeah, this is great. Well, man, it blows me away at how fast an hour can go by when we have these dialogues. And it's really thanks to you two, but all the attendees. I really appreciate you guys sort of feeding us with questions and comments. And I really love this new format. I mean, this is a great example of how those old in-person meetings we did, as much as I love them and as much as I miss them, I really feel that there's this level of convenience and efficiency with these types of meetings in terms of sharing resources. It's just fantastic. Let's see, Karen's got another one here. I'm being creative with options for my patients, using many areas, including Airbnbs and home care companies that will provide care to COVID positives, as well as assisted livings willing to take these patients, but need to plan to do so. This is great to hear, and I know it's not easy to find those resources because there are varying degrees of assisted livings and providers, many that are saying, no, we're not taking any new patients. We are just not doing that. And then there's others that are saying, yes, we are, but here are the restrictions. And as providers, we've, have to get on the phone and really start searching around. As I'd mentioned to you guys, I'm working with Dr. Amy and Dr. Alex on hopefully getting a database together that will not only help us get through this, but also into the future. So hopefully we'll get some of that going here in the short term. But we're wrapping up things here. So I really appreciate everybody. And Karen is mentioning that most ALs will not take COVID positive patients at this point in time. Anyways, all right, guys, we're gonna wrap things up. I'll be posting info and events on the Positive Aging online community, making some changes this week that's gonna make that easier to engage and a little bit easier to understand. I will save and email everybody the transcript from the chat, as well as a copy of the video if you want to reference it later down the road or share it with any loved ones or colleagues. And Christine and Deanna, any closing thoughts or things that you want everybody to know about?
I think in summary, I think I'm preaching to the choir when I say this, but these times really highlight the importance, I think, of home-based primary care. I think, Christine, you would totally be in agreement with the fact that we are really providing that sort of intensive, thoughtful, attentive care that older adults not only need, but they want. When I'm older, I want that care. And so I just encourage us to think about our home-based primary care providers, especially during this time, because we are accepting patients and we are happy to discuss all sorts of scenarios that are now coming up that we never would have thought of before.
Yeah, I mean, really well stated. And again, kind of, you know, the home-based primary care practitioner now comes in all shapes and sizes and formats. And it's really, you know, figuring out where that person lives and who can provide care in that region and what platforms are available, you know. So Christine, any closing thoughts?
Well, same, very well articulated, Deanna. Thank you, because this is we are a team, and when I walk into a home, it's not just me; it's the team that is behind me, figuratively. There is a net. There's a safety net for our homebound that exists that providers like myself gather together and tap into and create a very strong support system there. And it still exists even in this moment of technology. And I'm happy that we still can have these relationships that with my patients and continue supporting them during this time. I think that technology is not to be feared. This is not my first choice by any measure. I do miss.
I don't think any of us.
Yeah, I miss that hand on the shoulder. But you know, they are so pleased just to see a familiar face on that FaceTime chat. And so, thank you, Steve, so much for providing this time so we can build that home care system even stronger now going forward.
All right, guys, I'm pressing the end meeting button, and we'll see you later. Okay, bye-bye.